will join sharp at 7.
Yeah, no problem.
Yes, sir. Thank you, sir, for joining.
Sushmita, when are we starting? Dr. Malhotra, I spoke in the morning. Dr. Shamal said also. I'm sure they must be joining. And 7, we can have the countdown.
Yes, we will start sharp at 7. And if
But
they
we always for chief guest and the guest of honor.
if they join late, ma'am, then we will start with sir talk. Yes.
Okay. Yeah,
Yeah.
because Dr. Malhotra did tell me he'll join, but Dr. Shamal said told me that he'll be joining late in between. So let's just give a call to Dr. Malhotra.
Yes, ma'am.
Because everybody is in between from this webinar to that webinar.
Yes.
From Indore to Mumbai to Ahmedabad. Hi, Aishwarya. You have to unmute yourself.
Yes. Hello, good evening, ma'am. Good evening, sir.
Good evening,
Aishwarya. Good evening.
I hope Dr. Malhotra is not forgotten, but I'll just speak. सर को लिंक भेज दिया था सुष्मिता. डॉक्टर नरेंद्र मल्होत्रा को लिस्ट भेज दिया था.
जी भेज दिया था.
Call him up, na?
Yeah, I'm calling him. सर ने क्या अपना पिक्चर चेंज कर दिया है तो ढूंढने में टाइम. Best thing is to call his associate Ravi. Hello, sir. Good evening, sir. Waiting for you to join. Dr. Anem is joining. So you, Sudeep ji, you can सर का stop share करके आप उसका लगा दीजिए. सर का परफेक्ट चल रहा है बिल्कुल.
लैम्प लाइटिंग.
हाँ, वो सर को आने दो. सर इज ज्वाइनिंग.
ओके.
मल्होत्रा इज ज्वाइनिंग. और सर पुणे कैसा है? हाउ इज पुणे?
Quite hot.
यहाँ तो सभी दूर गर्मी है.
40 degrees.
क्या बोल रहे सर? हमारे यहाँ 43 है. इंदौर में.
And evenings are quite okay.
हमारी तो अभी इवनिंग भी गड़बड़ हो रही है इंदौर में.
अरे बाप रे.
No, it is so hot, very hot.
Evenings we have around 23, 24 at
Hmm.
night and evening.
That's good, sir.
Quite pleasant.
Hmm. You're settled in the new place?
Hmm?
Settled now, house सब
Just
set.
now in the rental place,
Hmm.
waiting for Kalpata to give possession from a month's time.
I'm sure they are good builders. They'll give. We have
Yeah.
Kalpataru in Indore also.
We are not in hurry at all. बोला तू बराबर काम करके ले और then
Hmm.
you give it to us.
True, sir.
Aishwarya is what?
Sir, Aishwarya is
Master of ceremony.
yeah, explain.
Please.
Tell yourself, she's a young gynecologist, very dynamic, very
Uh-huh.
smart girl, and Anshu's the batchmate.
Wow.
Yes, and batchmate classmates, and they are good friends also. And she runs her own hospital with a
Uh-huh.
Dr. Minesh. What's the name of your hospital?
Energy Hospital.
G Hospital. Her father is
Yes.
Surgeon.
son.
Yeah.
So she's a very, very bright girl, very, very brilliant.
Thank you.
So I think, Doctor, just 2 minutes more, and then we can start with the limp.
Yeah, no problem.
Yeah. सर की टॉक रेडी एकदम चेक कर लिया है.
Sir is teacher of teachers.
Thank you.
I'm so really happy. I have both the mentors here today, NM and PK. I started my ultrasound training courses under their residency and their advices. So let's just wait for sir. So, Sushmita, have you done the flow like how you are
Yes.
introducing or Aishwarya introducing what?
Yes, I have told you.
You're done, no? Already. When Sushmita is there, I don't check anything.
No.
But she's such a seasoned person.
और आप तो हैं, कुछ भूल चूक होगा तो माफ कर देंगे और क्या.
Sir, good evening, sir.
Hello.
Sir, one
Sorry,
webinar
थोड़ा सा.
to another webinar. You are the person in demand.
अरे यार पूछो नहीं.
In OT
I
also.
just finished and then.
कविता का finish
Yeah.
किया, फिर इधर आ गए, फिर इधर आ गए.
क्या करें, तुम लोग छोड़ते ही नहीं.
अरे सर, तो कैसे छोड़ेंगे? How do we leave you? छोड़ने का सवाल ही नहीं उठता है ना सर.
ठीक है, ठीक.
चलिए sir, we
चलो.
are waiting for you. So Sushmita, please tell Sudeep. And Shamal sir has also joined. That's fantastic. He was telling that I'll be late, but I'm really so happy that Shamal sir has also joined. So
Wow.
I think we can start.
Yes.
Good evening, everyone.
Good
Hi,
evening.
good evening.
Good evening, Shamal.
Sir, good evening.
Good evening. So good evening. I welcome you all to a very important webinar on preterm birth, and we have excellent esteemed faculty. We have Dr. Narendra Malhotra sir as chief guest and Shamal Seth sir as guest of honor. And apart from that, we have none other than Dr. P.K. Shah sir and Dr. Archana Basir ma'am for their excellent talks. So I will request Aishwarya to invite Malhotra sir.
Good evening, everybody. I would like to invite our chief guest for today's webinar, Dr. Narendra Malhotra sir, who is also a past president of Proxy.
I think there is a long list actually. Everyone knows sir, and there is so much to tell about him. From, I don't know, since when we have attended so many lectures, so many workshops organized by sir and ma'am. We welcome you, sir. And you are past president ISPAT, past president ISAR, vice president SAFOC, member FIGO Guidelines Committee, president FOXY 2008 to 2009, dean ICMU 2008, director Ian Donald School of Ultrasound India, national tech advisor for FOXY Geo, MacArthur Foundation EOC course, director ART.
Thank you, Shrishmita. Thank you.
Let me introduce sir from my angle.
Yes.
Professor Dr. Narendra Malhotra, I know him is a person ever ready. That is my thing. Ever ready means you tell him, sir, there's a lecture. Will you take it? If the time is there in his calendar, he will never say no. Sir, you will come chief guest, GOH. I don't know, it is my luck or I am blessed. I've never heard no from Dr. Narendra Malhotra. And I think I'm really lucky and I'm blessed that both of my mentors in the imaging science committee of the FOXY are here today. Dr. Narendra Malhotra was the one who has guided me to the imaging science in the FOXY, and Dr. P.K. Shah is the one who called us on the 1st January. I will never forget, in Mumbai, to instruct us how to really run the ultrasound courses. And so both of them are here, and I'm really very, very lucky. And so over to Dr. Malhotra for preterm labor. I've heard Dr. Malhotra several times talking on preterm labor. And let me tell you, I am using the pessary because I was introduced to the pessary by Dr. Narendra Malhotra when from in the Agra, and we are getting it from Agra still. So, Dr. Malhotra, over to you to bless us for this webinar and give your piece of advice to us.
Thank you very much, Dr. Archana, and all the organizing team for inviting me to this wonderful webinar series. Good evening, everyone. Namaskar. As you all know, India is the preterm birth capital of the world. And that puts a huge amount of burden financially on the parents, huge amount of burden on the healthcare system and the NICUs for manage these preterm babies. So somehow we have to try to prevent preterm birth. And when we were preparing for this lecture, there is one island where there is no preterm birth. And because they eat a lot of fish. So omega-3 in your diet prevents preterm labor. And then, of course, bacterial vaginosis, your gut microbiome. So many things are important for maintaining the pregnancy. And of course, the drugs like progesterone and all. Now, when it actually starts, or when the or starts opening or shortening, which we can now study at 13 weeks at the time of NT, and then at 20 weeks. then what we used to do is put a McDonald's stitch, and that also with silk. So now you have Merceline tape with both end needle to put those McDonald's stitch so it is safer. And now we have Ariban pessary. Now we've done the first thesis in India on Ariban pessary at Agra Medical College and shown it to be as effective as a McDonald's stitch put in labor. And sometimes when the stitch does not hold, even the pessary can be put over the stitch. It's a simple pessary. It's not a pessary like prolapse. It has got holes and it is made of silastic and it is very, very easy to put. To remove, you have to cut it before the labor sets in. So, and let me tell you, when I was in the PIGO committee and we were discussing about guidelines of preterm labor, uh, there was a story that how to do research in preterm labor, especially fibronectin and the other newer markers. So there was no funding for it. Now, in the Second World War in America, to generate funds, there was what was called as the March of Dimes. Now, dime is a 4 anna coin of the American dollar, or 25 cents. So every road, every crossing, a big box was put with where people used to go by and put dimes in it to collect money to fight the war. Now they collected so much money that the war finished and a huge lot of money is still there in the bank. And this money is now being used for preterm labor. Joe Simpson is leading this research, and it is called as the March of Dimes. So those are some interesting things. Your diet, how pregnancy is, pre-pregnancy evaluation, judicious use of progesterone, a very good use of ultrasound to judge the shortening of the cervix transvaginally. Please don't get afraid of doing transvaginal scan. A transvaginal scan is safer than doing a PV in patients who come with preterm labor. Because in PV, you will go into the os. With transvaginal, we are away from the cervix to measure it. And that is how we accurately do. So, and of course, our good friend Dr. PK Shah is here, who will be telling you about neuroprotection and prevention drugs. And I think he's going to talk on Magsulf. Magsulf, which was used for eclampsia, showed that it is neuroprotective in preterm uh, children's and preterm fetuses, preterm newborns who had the white degeneration of the brain. If Magsulf is given before 24 hours before, you can prevent that white degeneration of the brain and that mental retardation can be prevented. I'm sure I'm looking forward to listening to our friend Dr. PK Shah and to Archana Baser on this wonderful deliberation of preterm labor. All the best to all of you. Let's get together and prevent preterm births. Thank you for inviting me here.
Thank you, sir.
Thank you.
I think this is a very nice let's prevent the preterm birth, because preterm, we know the morbidity, mortality associated with preterm. So wonderful advice, and everything you have covered, that how really we can do prevention of preterm labor. So now over to you, Sushmita, again for Dr. Shamal.
So now I will invite our star performer, our candidate for President Foxy, Archana Basil ma'am, our mentor, and madam, we know you as the most dynamic person, always updated, always guiding, and you were Vice President Foxy 2020, Chairperson MP ISA 25 to 27, Fellow Representative AICC RCOG West Zone, Joint Secretary ISPA 25 to 27, Organizing Secretary AICOG 2021 Indore, and past positions, Chairperson Foxy Imaging Science Committee 2015 to 2017, Organizing Secretary ISAR 2016, Managing Committee Member ISAR 2018 to 20, IG 2018 to 2019, ICOG 2017 to 21, Imaging Science Member AOFOG, Imaging Science Committee Chair, SEFOC 2020-2023. She is the Foxy presidential candidate election year 2026 and also Guinness World Record holder. So I would request you, Madam, to say a few words and also introduce our guest of honor.
Thank you, Sushmita, for the kind words. And I welcome you all to this webinar with such a good talk, which I'm really looking forward to hear from Dr. P.K. Shah about the magnesium sulfate. We just now heard Dr. Naren Malhotra about how that we need to prevent the preterm, and all of us should work united towards preventing the preterm labor. And it is my pleasant duty now to invite our guest of honor, Dr. Shamal Seth. Dr. Shamal Seth is a very humble person, and again he will say, okay, Archana, I will come. He is consultant gynecologist, Kolkata, and he's the one with an LLB, medical legal expert you can go to. He is president-elect, the Bengal Obs and Gynae Society, vice president of Foxy 2025, a good friend and a very well-read person. So over to you, Dr. Shamal Seth, for your words of wisdom on this webinar.
Thank you so much for all these kind words. And now, whatever Dr. Malhotra had said, I don't think anything is left to speak on this preterm birth and preterm labor. We have two prolific speakers. Dr. P.K. Shah will highlight absolutely on the necessity of magnesium sulfate in case you are dealing with a preterm labor. And he will be speaking on the role of sarclage at different stages. The concept is gone. Now you can give sarclage whenever it is required, when you are coming across a patient who may be going into preterm labor. And I think panel discussion will also deal with the different case scenarios, which will highlight how to identify the risk patients who are subject that may proceed to a case of preterm labor. Now, to identify the factors responsible behind, to identify the patients who are actually threatened preterm labor, and to prevent all those patients to proceeding into an established preterm labor. So there is the challenge by the obstetricians. Today, we are in an era when we do not want our patients to deliver before at least 34 weeks. Even if a patient is having so many high risk factors, we are comfortable to deliver her after 34 weeks at most of the setups, having a good NICU backup. But before that, we always want to have the patients for the prevention of preterm birth. And there comes the role of magnesium sulfate in case you are dealing with really a preterm birth that you are apprehending that you cannot check, and now she is going to deliver, and role of sarclage. And I think all those things, what Dr. Malhotra pointed out, all the role of these pessaries as well, how they are going to give a beneficial effect, and at least something at our hand that we can tackle, we can deal with a patient who is probably is going to have a preterm birth or preterm labor. Thank you very much for inviting me to be in this webinar. I believe whoever is attending are going to be of benefit from the speakers and the panel discussion. Thank you very much. All the best. And Archana, best wishes for your candidature and contest for the Foxy.
Thank you. Thank you, Shamalda. It was really our pleasure that you could attend and you could come and join this webinar. And thank you for your kind words. And we will do justice to the topic, preterm labors, because we have none other than Dr. P.K. Shah as a speaker. So over to you, Dr. Sushmita and Dr. Aishwarya, to introduce our first speaker, Dr. P.K. Shah.
Sir, we'll be speaking on role of magnesium sulfate in preterm labor. He is professor and unit head, Department of Obstetrics and Gynae, LTM Medical College and LTMG Hospital, Sion, Mumbai, SAID, GS Medical College and KEM Hospital, Parel, Mumbai.
I am not contesting for any post, so I would love to have some more minutes for my talk. Thank you so much.
Thank you, sir.
That's what the legends do.
You don't require, you don't require only. Thank you.
Can you remove my slide so that I can share my screen? But before I do that, I would like to thank Dr. Archana Baser, who is the program director of this Shrinkhala for academic webinar series. And it's so nice to see that today's topic is preterm labor, preterm birth prevention, and management, the latest updates. I wish you all the very best for your presidential candidature for the year 2026 when the elections are. So nice to see convener Dr. Susmita and the office bearers of IOGSA, Dr. Sumitra, Dr. Sunita Chauhan, and nice to see my very good friends, chief guest, Dr. Narendra Malhotra, whom I know for 4.5 decades, and Dr. Shamal Seth, who was the vice president last year and is going to be the president of Bengal OBGYN Society in near future. So nice to have these two very important personalities of Foxy for my talk. Now, you have also a panel. I'm sure it is going to discuss most of the things about preterm labor. But my talk is actually on IV magnesium sulfate. I was told to talk only on preterm labor, but I thought I will finish it in 5-6 minutes. So I have included magnesium sulfate in obstetrics for today's talk, and I'll try and finish my talk as early as possible.
No, sir, take your time, not a problem.
Thank you. Why is it not moving? Okay. Magnesium sulfate is a real savior in pregnancy-associated complications for fetal neuroprotection in preterm delivery, slowing or stopping premature labor, and preventing seizures in women with eclampsia and severe preeclampsia. So let us see the first thing first, that is magnesium sulfate intravenously in preterm fetal neuroprotection. Babies born preterm compared with those born at term have a higher chance of dying in first few weeks of life. We all know that. Those who survive have a greater risk of neurologic impairments, including cerebral palsy, cognitive dysfunction, educational difficulties, and psychiatric disorders in adulthood, which increase with increased educational and societal costs. So, antenatal magnesium sulfate is recommended for neuroprotection of the fetus in women at risk of very preterm birth. So, what is a preterm birth and CNS injury? Pathologically, there are two central nervous system injuries. One is intraventricular hemorrhage, and second is white matter injury, which can be diagnosed with MRI. Clinically, the most frequent adverse CNS outcomes are cerebral palsy, cognitive impairment, blindness, deafness, and developmental delay. Now, how does magnesium sulfate help in neuroprotection? There are multiple mechanisms that for neuroprotective impact of magnesium. Magnesium is a non-competitive antagonist of the glutamate NMDA receptor, and it causes increased extracellular magnesium. It blocks calcium influx into the cell, blocks neuronal injury. Also does stabilization of membranes, increase cerebral blood flow, prevents large blood pressure fluctuations, does reduction in pro-inflammatory cytokines, and has antioxidant effects. So what are the recommendations? The recommendations are coming from almost all the international and national organizations, FOXI, Gestosis, ICOG, WHO, FIGO, etc. So what recommendations are there from these FOXI, Gestosis, ICOG? Good clinical practice recommendations that magnesium sulfate is indicated when very preterm birth is imminent before 32 to 34 weeks to reduce risk of cerebral palsy. The optimal time is when preterm birth is expected within 24 hours or decision for iatrogenic early delivery has been taken. Ideally, begin at least 4 hours before birth, but give even if delivery is sooner, some benefits persist. what is the dosage? 4 gram intravenously, loading dose over about 20 minutes, and then followed by 1 gram per hour intravenous infusion until birth or up to 24 hours. Stop after 24 hours if undelivered. Repeat dose can be offered if next episode of preterm labor occurs after 4 weeks or as and when required. Now look at the recommendations coming from various places for neuroprotection. Australia, New Zealand, Canada, Ireland, Belgium, UK, FIGO, WHO, France, USA. All of them say that you can give it up to 32 weeks. Loading those 4 grams and maintaining those of 1 gram per hour for maximum 24 hours. Now we all know that internationally, there are some brands of magnesium sulfate available readily, especially from Braun et al. They have magnesium sulfate in water for 24 hours. Magnesium sulfate in water for injection, 4 grams in 100 cc. Even in India, we have magnesium sulfate ready to use available brand, ready to administer solution will resolve the errors in dosage calculations and associated complications. It's easy intravenous administration, no confusion and error in dosage preparation, and observed magnesium toxicity can be avoided by stoppage of infusion at any time. We have now IVMAC 4 gram of magnesium sulfate per 100 cc available in India. I'm sure all of you will remember, we used to break those 50% magnesium sulfate, take out 8 cc from there, dilute it with 12 cc of distilled water, and make 20 cc of 20%, that is 4 grams, and give it. Now, you don't have to do all that. You have a ready-made solution available to us. Now, there are various magnesium sulfate clinical trials for extreme prematurity neuroprotection. Infants received magnesium sulfate were less likely to require invasive mechanical ventilation in either day 1 or 3 of life compared to control group. It has a protective effect on the need of invasive ventilation in preterm infants. Neonates with antenatal exposure to magnesium sulfate had more days free of respiratory support in first 28 days of life. Hence, protecting neonates from adverse effect of excessive oxygen, such as retinopathy or prematurity. And there are 100 women in this group published in Journal of Obstetrics and Gynecology in 2021, and the control group had no magnesium sulfate. Now, effect of magnesium sulfate for antenatal mothers in preterm labor for neuroprotection in infants. A nice prospective observational study. What was found in this? This was International Journal of Clinical Obstetrics and Gynecology of 2021. Apgar at 1 minute was 5.78 plus minus 1.64, and at 5 minutes, 7.44 plus minus 1.49. And about 92% of the neonates were normal when they were given magnesium sulfate before the preterm delivery. Prenatal magnesium sulfate given for fetal neuroprotection before preterm birth avoids cerebral palsy and lowers the combined risk of fetal infant death or cerebral palsy. What happened when antenatal magnesium sulfate was used for neuroprotection and extreme prematurity? The intraventricular hemorrhage incidence was reduced to half. So what was the conclusion of this paper that was published in Journal of Obstetrics and Gynecology of India in 2021? That Maxalt is a safe drug to use in antenatal women at risk of impending preterm. Antenatal magnesium sulfate confers significant neuroprotective advantage to neonates. It's the time to start using magnesium sulfate in clinical practice for neuroprotective intent in all our extreme preterm births. This is a very good paper in Obstetrics and Gynecology 2009, effect of antenatal exposure of magnesium sulfate on neuroprotection and mortality in preterm infants. Meta-analysis of 5 RCTs involving more than 5,000 fetuses. What was the conclusion? That fetal exposure to magnesium sulfate in women at risk of preterm delivery significantly reduces the risk of cerebral palsy without increasing the risk of death. Cochrane review, magnesium sulfate significantly reduced the risk of cerebral palsy in child and substantial gross motor dysfunction. So magnesium sulfate had no significant effect on pediatric mortality. Now, what is the cutoff gestational age for magnesium sulfate? Although there is controversy about upper gestational age, antenatal magnesium sulfate for fetal neuroprotection should be considered from viability, that is about 24 weeks to 31 weeks, 6 days. If antenatal magnesium sulfate has been started for fetal neuroprotection, tocolysis should be discontinued. Should delivery be delayed to give magnesium sulfate course, like how we delay the delivery in preterm to give corticosteroid? The answer is delivery should not be delayed if there are maternal and or fetal indications for emergency delivery. So what is the summary? Protecting brains of premature babies, magnesium sulfate is recommended for neuroprotection of the fetus in women at risk of very preterm birth. Significantly reduces adverse clinical outcomes in preterm birth and significantly reduces pediatric mortality and cerebral palsy incidence. Now, slowing down or stopping premature labor, how magnesium sulfate works. It has an added advantage of fetal neuroprotection if delivered. Preterm labor refers to progressive cervical dilatation in placement associated with regular uterine contraction, less than 6 per hour. An imperative factor in infant deaths and second cause of infant mortality followed by congenital anomalies. Abortion, history of C-section, preeclampsia are reported to be significant causes of preterm labor. Tocolytics are used to delay the active phase of labor for at least 48 hours. Magnesium sulfate, prostaglandin inhibitors, calcium channel blockers, nitric oxide releasing drugs have shown positive effects on preterm birth. The use of tocolytics such as magnesium sulfate is one of the regular treatments to prevent preterm birth. When it was used in preterm labor, what happened in singleton gestation with intact membrane? 76% gained 48 hours before delivery, 51% gained 7 days, and 39% achieved a full term delivery. Magnesium sulfate compared with nifedipine of acute tocolysis of preterm labor, a randomized controlled trial showed that magnesium sulfate group was successful in arrest of preterm labor in 87%, whereas it was 72% with nifedipine. There are various trials. If you see this magnesium sulfate versus isoxazoline, look at the last part of conclusion that better perinatal outcome were observed with magnesium sulfate. Magnesium sulfate is comparable to isoxazoline in its efficacy in managing preterm labor with less maternal and neonatal side effects, and magnesium sulfate was slightly more effective in arresting preterm labor with lesser side effects as compared to isoxazoline. So what is the summary of slowing or stopping preterm labor? Inhibits uterine contractions and delays the delivery by increasing the active phase of labor, arrests the preterm labor, and significantly reduces the respiratory distress syndrome. It has an added advantage of fetal neuroprotection if delivered. Now, this is what I have added, and I'll finish it in few minutes. Magnesium sulfate in preventing eclampsia in women. We all know hypertensive disorders account for 14% of global maternal deaths. Preeclampsia and eclampsia are hypertensive disorders of pregnancy experienced by 4.6% and 1.4% of women, respectively, during pregnancy and childbirth. I'm not going to go into these details, but annually, both eclampsia and preeclampsia account for nearly 63,000 maternal deaths worldwide. Hence, timely intervention and appropriate management of this detrimental condition is extremely crucial. How do you manage severe preeclampsia? We all know that antihypertensives, any one of these, nifedipine, hydralazine, labetalol, anticonvulsants, magnesium sulfate, and corticosteroids to improve development of babies' lungs. And this is all by most of the organizations from our country and abroad. It is a gold standard anticonvulsant of choice. Magnesium sulfate is recommended by WHO for women with severe preeclampsia and eclampsia, and administering magnesium sulfate to women who have preeclampsia halves the risk of developing eclampsia and more than halves the risk of death So what are the recommendations? NICE guidelines, National Institute for Health and Care Excellence. Loading dose 4 grams should be given intravenously or 15 to 20 minutes, followed by infusion of 1 gram per hour, maintained for 24 hours. If the woman has had an eclamptic fit, the infusion should be continued for 24 hours after the last fit. Recurrent fit should be treated with a further dose of 2 to 4 grams given intravenously over 15 minutes. Do not use diazepam, phenytoin sodium, or other anticonvulsants as an alternative to magnesium sulfate in women with eclampsia or severe preeclampsia. There is a very strong recommendation coming from World Health Organization for use of magnesium sulfate for severe preeclampsia and eclampsia. What is important is routine monitoring of serum magnesium level is not recommended. Please remember this. So what is the dosage regime? You all know very well. 4 gram IV loading dose followed by continuous IV infusion of 1 gram per hour. That is Zuspan's regime. And we all know this Pritchard's regime of loading dose of 4 gram intravenously, 20% 20 cc. 5 gram intramuscularly on each buttock, followed by a maintenance dose of 5 gram intramuscularly every 4 hours. Now, I have a suggestion to all those who have joined us today. Please stop Pritchard's regime in practice. It is absolutely painful to keep giving intramuscular injection to a woman for 24 hours. Zuspan's regime is most commonly used and it is better over Pritchard. Because it is found that the serum concentration of magnesium obtained from Pritchard's regime fluctuate more often compared to the Zuspan's regime. Now coming to various magnesium sulfate clinical trials for severe preeclampsia. This was in British Journal. The incidence of eclampsia was reduced to 0.3% of magnesium sulfate was used, and when placebo was used, it was 3.2%. Magpie trial, I'm sure all of you know very well. Probably, do women with preeclampsia and their babies benefit from magnesium sulfate? It was 10,141 patients. Intervention group, magnesium sulfate Zuspan's regime. Sorry, it was not Zuspan's regime, but it was Pritchard's regime, and the control group had a placebo. What was found in Magpie's trial, that the number of eclamptic fits were reduced to half when magnesium sulfate was used, and the maternal death also came down from 0.4% when placebo was used to 0.2%. So there were significantly fewer eclamptic conversions among women allocated magnesium sulfate than among those allocated placebo, and this represents 58% lower relative risk of eclampsia. Maternal mortality was lower among women allocated magnesium sulfate than in those allocated placebo. So, magnesium sulfate prevents progression of severe preeclampsia to eclampsia, 58% lowers the risk of eclampsia, reduces maternal mortality, and superior over other competitors. There is no substantive harmful effect on the mother or the baby. And you can use this ready-made magnesium sulfate IV mag. Easy to administer intravenously, no pain of intramuscular administration, no confusion and error in dosage preparation. Observed magnesium toxicity can be avoided by stoppage of infusion. You can give one in 15 to 20 minutes and have 6 more such bottles of 4 grams in 100 cc for next 24 hours. Now, how to administer 1 gram per hour with infusion set? If you have a macro set, the one that we use 8 drops per minute, you will have 25 milliliter per hour. If you have a micro set, use 25 drops per minute. That again will give 25 milliliters per hour. What are the observations and care during magnesium sulfate infusion? Continuous CTG, monitoring if more than 26 weeks of gestation. If it is less than 26 weeks, perform 30-minute auscultation. Sorry. What maternal observations are required when using magnesium sulfate infusion? Respiratory rate, any possible pulse oximetry, if available, every 30 minutes BP monitoring, every 30 minutes maternal pulse hourly, urine output hourly, and patellar reflexes at the completion of the loading dose, and then every 2 hours. Measurement of magnesium sulfate level is not necessary unless there are signs of toxicity. What are the signs of magnesium toxicity? Respiratory rate less than 10 per minute, or saturation of oxygen less than 90%, muscle paralysis, absent reflexes, and if the toxicity is suspected, stop the infusion, take blood for magnesium level and send it. What is the treatment of magnesium toxicity? Administer calcium glucose at 10% intravenously, 10 cc over 10 minutes. Please try and keep these levels in your mind. Whenever there is magnesium toxicity, you should have 4 to 7 milliequivalents per liter of magnesium, which is therapeutic range. If more than 7, the patellar reflexes are lost. More than 10, respiratory paralysis occurs, and if it is more than 25 milliequivalents per liter, you will have cardiac arrest. So, magnesium sulfate is a real savior in pregnancy-associated complications for fetal neuroprotection in preterm delivery, slowing or stopping preterm labor, and preventing seizures in women with eclampsia and severe preeclampsia. Thank you very much, ladies and gentlemen.
Thank you, sir. It was a very nice presentation, sir, very enlightening and brushing up the concepts. And I would like to invite Dr. Archana Basir ma'am for the further discussion on this topic.
I think once the professor has spoken, there is no discussion thing left, because he has covered each and everything. I think this is a new kid on the block for preterm. I think when we know that we want to not have preterm babies, right? But we are living in an era of ART where the multiple pregnancies are there, where there are, the women are working, and they have a lot of stress. Yesterday only I was talking somewhere that we do not realize how much stress impacts the pregnancy outcome. Because of the we do label that the preterm may be because of infection, because of the previous preterm, but we are overlooking, that stress factor, because long working hours, sitting longer time, and then finishing the task on time is also leading. So whatever said and done, we as an obstetrician will make all of our efforts to control and not to have the preterm birth. We'll have the remedies to stop the preterm birth. We'll have the sutures, pessaries, and everything. But what is most important is, suppose if it happens, the preterm happens, or preterm is at the verge when you cannot stop the preterm, I think we really need to think of preventing or at least controlling the intraventricular hemorrhage and the complications of preterm. So here comes the role of magnesium sulfate, because we know that steroids are there for the lungs, and then that reduces the chances of going baby to the venti and then the respiratory problems. But we all know that intraventricular hemorrhages are one of the very, very, the serious problems of preterm. So we all should learn how to use the magnesium sulfate. And the most important is when to use the magnesium sulfate in the preterm. It's not like steroid, give 15 days. When it is imminent, you know that it's going to happen in next 24 hours. That's the time you should use magnesium. And the other roles of magnesium are very well pointed out by Dr. P. K. Shah in the preterm. So I think one and all, it was a wonderful listening to Dr. P. K. Shah.
Thank you.
Thank you, sir. Now we move on to our next talk. For that, I would like to invite Dr. Archana Basir ma'am. She will be talking on cervical cerclage in prevention of preterm birth, a new technique. So,
Thank you, Sushmita. I think I'm already being introduced. So if I may be allowed to share my screen, I can start sharing, and then I go to, yep, I think we have beautifully covered the problems which we are going to face in the preterm by Dr. P.K. Shah. And my talk is cervical shortening. How do you predict and how do you prevent the preterm labor from happening? And there is one of our innovation where we have modified the few existing techniques and done the cervical circlage in cases of the previous mid-trimester miscarriages and failed McDonald's sutures. So this is why it is important. I think our guest of honor, chief guest, and previous speakers have highlighted the preterm labor accounts for 85% of all morbidity and mortality, and treating established preterm labor is unsuccessful. So prevention is the key. And where do we stand in terms of preterm? About 20 out of 27 million babies born every year in our country, 3.5 million babies born are premature. So there is a global burden of preterm. Almost 15 million babies are born preterm annually, and indicating a global preterm birth rate of 11%. So that is very, very important for us. So now I'm quickly moving on to how to predict preterm labor. I think the most important thing is the history, clinical examination, previous preterm, fetal fibronectin, and cervical length assessment by ultrasound. The methods of evaluating the cervix by ultrasound, that is my favorite topic. And I always insist that measure the cervical length at every anomaly scan at least once, and in the previous history of the preterm, start assessing at the 16 weeks. You can measure the cervix by transabdominal ultrasound, transperineal ultrasound, or transvaginal ultrasound. Transabdominal ultrasound, it needs a full maternal bladder, which can falsely elongate the cervical length, and external os may be difficult to visualize. And if you are doing a transabdominal, 3 centimeter is the lower limit of normal. You can do a transperineal ultrasound by placing the probe sagittally between the labia majora, and it does not require full bladder, and you can very well correlate it with the transvaginal scan. Sometimes the rectal gaze and symphysis pubis may obscure your view. This is the favorite thing, which is a gold standard, most accurate, reproducible, and 2.5 centimeter is the lower limit of the normal. Now, I'm not going into detail of technique of cervical length assessment by transvaginal scan. Only one thing I can say, that it is very easily learned skill, and it can be done well, and it is a really, really, what I should say, is a life-saving thing, or it can really help you prevent the preterm from happening. And only difference from a cervical length assessment in a non or early pregnancy and mid pregnancy is, do not put lot of pressure, do not touch the probe to the cervix, keep it in the mid vagina, so that you are avoiding the pain to the patient. And another thing is, you're not unduly stimulating the uterus, number one, and excess pressure can result in elongation of the cervix. So this is how you measure the cervical length. You see this
Showing
is
the corresponding image that you will
this is a
see
sagittal
on
view.
the probe position. So if you keep the probe like this, then you will see a sagittal section as shown here. Showing the
And then you have to do, this is how you measure the cervix, the cervical length, the funnel length. A is the funnel length and B is the cervical length. So you have to record that. The advantage of the ultrasound measurement of the cervix over the digital examination or the inspection is, because when you are doing a digital examination or visualizing, you are only seeing the external os, and if the internal os has started dilating, you are not going to appreciate it without ultrasonography. So that's what it is important to do, a ultrasonography to measure the cervical length. So these are the sonographic features of cervix associated with preterm delivery: funneling, shortening in response to fundal pressure, and intraamniotic sludge. So this is how internal os is here, then the external os, and whenever you are putting pressure, what will happen, there will be elongation, and they should measure the anterior and the posterior lip of the cervix. Both should be measured, and these are the shapes of the cervical funnel, T, Y, V, U. So U means it is completely dilated cervix and eminent preterm birth. So this is our aim, that whenever you are scanning And if you are seeing the why, you have to start intervening at this stage. And by the time you are here, you probably might need to do the rescue circulage. And if you are here, just imagine that, just predict that yes, it is going to happen and you are going to have the preterm baby. And this is a picture of U-shaped cervix by the ultrasound. And these are the short cervix. You can see the external loss is closed, but internal loss is funneling and there is a fluid. And this is here, there is a sludge is there in the cervix, and cervical length is only 15 millimeter. Another thing which is very important is the straightening of the cervix. What happens when you are measuring the cervix, there is a little curve in the cervix. When it is straightened and short, you know that it is a imminent preterm. So this is how you can measure the cervix, a curved cervical length. This is a normal cervix in the mid trimester of the pregnancy, and these are the different cervix. And what patient should be screened? Should you be screening everyone? I think yes, all women at the target scan or TIFA scan. Sonographically, short cervix length less than 25 during mid gestation is the most powerful predictor of preterm birth. Now, indication of cervical length measurement in high risk asymptomatic women, in symptomatic women, and in multiple gestation, and especially in the previous preterm birth. Multiple pregnancy also measure the cervical length. And this is a graph which is showing when to screen gestational age for ultrasound assessment of cervix in pregnancy. When there is a previous history of preterm, 14 to 18 weeks, and primary gravida, no history of preterm birth, 18 to 22 weeks. And these are the RCOG recommendation. And I'm not going into the medication. I'm just straight away going for two small videos of ours which I find it is very useful. And many of my friends and associates and those who, they are asking me about, they want to see it again and again. So this is a case where we did the rescue circulage. I'm sure many of you must have done the rescue circulage, or if not, this is a very simple technique. Two speculum, two Ellis forceps, just good assistant and a good light. It can be done at a district level. Laparoscopic rescue circulage is a good method, but not available in emergency everywhere. And you need highly, you need to be more skilled in the laparoscopy. So this is a method, very simple. This is a 24-week primee who just came for a, 22 weeks. She came for a target scan, and my ultrasonography person informed me that, ma'am, her cervix appears dilated. We put in a speculum and we saw that there is a bulging membrane. I did a briefing of my team that yes, we have to do a rescue circulage. It looks very, very dangerous, that it's like anytime it can rupture. So just see that two Ellis forceps we are using. I catheterized the bladder, did a lot of counseling to the patient, because if a patient comes for a scan and you take her for a surgery, you really need to do a lot of counseling. So what I'm doing, I did put a Follis catheter, put 30 ml of normal saline in that. So that pushed my bulging membrane inside. And I'm taking the suture with the Vicryl anterior to posterior. And these sutures, I'm going to be holding them as a tenting sutures, not going to tie them and not going to, cut them also even at the end. And this all proceed, my associates are handling it. Now what is happening, the membranes have been pushed up. So, and this, by holding the Ellis forceps, cervical length is effectively increased. And by putting this stay suture, you can say I have got a little place to put my purse string suture. Otherwise, if you try and put the purse string suture before you take this, increase the length of the cervix, your needle might puncture the membranes, and then you will have a delivery, like you will come with the baby in hand rather than doing the suturing. Now look, I'm doing the purse string suture here after I have put the anterior to posterior suture, and then just tie it like your routine suturing what you do. So this is the true silk which is being used, and the needle of the true silk is little bigger. And while the 2-0 Vicryl which I used, the needle was thin. Just do a little bit of cleaning, and at the end tie the purse string suture. I tied my purse string suture first, and then after tying, because what happens sometimes you have to see that the bulging membranes are not outside, you are tying it over the membrane. So you have to make sure that the membranes bulging are very well pushed. And then this is the posteriorly you're taking the suture. Then I'm going to take the suture from the from the left side. So begin from anterior, right, posterior, and then the laterally you take the suture. And once you've completed it, you just tie it. We kept the patient for 4 to 5 days in the hospital, given her some good antibiotic. We took some swabs culture before we started the procedure, because it will take some time for the report to come through. But we had an emergency because it's a rescue circulage. So we did the procedure and changed the antibiotics as per the organisms which were shown in the swab report. So this is how now we're just going to be completing this rescue circulage. And this patient delivered at 34 weeks with a breech presentation. So I had to do an emergency a cesarean section for the breech. Um, Now let's move on. I think if there will be any questions, I'll answer on that. And I'm just going to be deflating the Foley's catheter, just deflating the Foley's catheter and just tying the vicryl suture. So this is a standard rescue circulage. I'll move on to the transvaginal transsystemic cervical circulage with anterior knotting. And this is our modification, and this is the method I actually wanted to show you. TVI, TTP, anyone who is doing a vaginal surgery can do it. Just put a circular incision, not full circular incision. Again, 2 speculum, 2 Ellis forceps, and just your Marcelin tape, and you can do this. So open the posterior peritoneum. Anterior we are not opening, and we are just palpate the uterosacral ligament and put your sutures from the side, and then you can just tie this. So this is a video, just watch it along with me. Semicircular incision. And just push the bladder a little up. You need to open the posterior peritoneum. Once you open the posterior peritoneum, look what we are doing from left side. Needle is being brought from the posterior to this lateral. You have to be very careful not to damage the lateral vaginal wall here when you are doing a you have to be very diligent, and you have to follow the curve of the needle and make sure that your needle goes not only in the, it goes into the good depth of the cervical tissue. So and then you will have the actual elongation of the cervical length. Then after you're done the one side, you have to go from the other side. You can see the Marcelin tape here. We put in a we put in a hysteroscope and saw that our tape is right. What is most important thing is you have to avoid that it gets turned and twisted. So one associate's job is to see that your this tape is held properly. So you are just putting from the other side, put it from the other side, pull it gently, and then before you tie, your do not tie it. You have really seen that all the hemostasis and everything is achieved. So let's just watch it. So how we are just taking out the needle, not at one go. You just have to now, since both of our tapes, anterior and posterior, have come, because the previous people have described the not posterior, this is modification what we have done, because what we found and studied, that anteriorly when you are doing, it is easier to remove, while posterior lip gets taken up earlier if the patient goes in labor. So this is the tape seen. If you can see, this is the tape seen at the cervicoischemic junction. And then this is the anterior cut end of the vagina, where we are just going to take our needle through it. And then we'll close the vaginal incision. So this is the anterior vaginal wall pierced with the needle on the left side. And just assessing, correcting the hemostasis. You need not open the anterior peritoneum, just push the bladder a little up. And you have to bring your needle over the speculum. I mean, speculum has to be held well so that no other, your needle is very precisely going. And after this, we will be just closing, just a little bit of bleeding will be there. And we did this under spinal anesthesia because you do need some time when you're doing this procedure, and short general the patient is moving, your anesthetist is all the time telling you that, oh patient, there is a problem. Also, it is better to do it properly with a good anesthesia. So we have now closed, and we have closed the anterior, our incision. We have closed the posterior incision, and we are securing the tape anteriorly. And this is the final picture, which you can see here. And then you cut the needle, just give it a little wash. Now the advantage of this is, of this technique is, even if like the patient goes into preterm, in spite of your all the efforts, it is, you do not have to go into the abdominal like what was used to be done in the previous preterm, previous failed McDonald's. They were used to do the transabdominal, and then you, for even preterm, you have to open the abdomen, so that it saves you from that. And this is the tape seen at the C-section. So means we are 100% like our tape was intraperitoneum, and this is the outcome. Term baby 2.3 kg was born in this case, where she had a previous 3 mid-trimester miscarriages, and she had previous McDonald's sutures also done. So this was our method, which for which we got our Foxy Movie Call Award. And this is the Arabian pastry, if anyone has interest in seeing. This is what we are also using very well, especially I'm using.
And it is very useful for, especially for high risk patients. This is the top that goes above, and this is the bottom that goes below. Now to insert it, you simply fold it longitudinally along the length of the vagina with a liberal use of local jelly, and you can direct it with your index finger. So we insert it like so. As you can see, it slides quite easily with minimal discomfort to the patient. And then you use your finger and your index finger to direct it and position it as high as possible in the posterior fornix to encircle the anterior and the posterior lip of the cervix. This is the ultrasound picture of the before the insertion, and this is the ultrasound after insertion of S. Thank you.
And so this, we found it very, very useful
Thank you, ma'am, for excellent talk on circlage and the innovations which you have shown will always inspire us. The main technique which I could find was to lengthen the length as much as possible. In case of rescue circlage, the problem is the length of the cervix. It is almost negligible. The membranes are coming out. So you have found out a technique where we are able to lengthen the length to some extent. And secondly, the laparoscopic circlage, it is a very good technique, but it requires a person who is very much trained, because putting the needles medial to the uterine vessels laparoscopically, where the vessels are very big, prominent, pushing the bladder and then taking a suture over there, it is a task. It is not easy. So before we conclude, I would request PK Shah sir to give his comments on Madam's talk.
Yeah, it is nice that Dr. PK Shah is here to come and
I'll remind you, don't worry, Archana. I have seen this earlier on also. I have heard you on this particular topic also, but I enjoyed thoroughly because there is nobody around me. So I could concentrate much more during your talk and the video. I think we all have been doing various procedures for shortening of cervix. And I'm thoroughly impressed that you have this simple method. I'm sure all the gynecologists can do it. And both modification also is equally good. And the pessary, it is something very simple, I feel. People can do it because if you ask the patient whether she wants either medicine or some procedure, which is not a surgery, or would she like to undergo surgery, she will never prefer surgery. I can assure you that.
Perfect, sir.
I think you have given both the options to all the listeners, and people can choose depending on the type of patient they have, and after the counseling with the patient, they can decide which method is good for that particular patient. Because we have seen that sometimes doing surgery on short cervix itself can lead to preterm labor.
Yes, sir.
People have done surgery and the patient has come back with bucket handle tears of the cervix. I think this should never happen. You have to be very sure that patient on whom you have done surgery on the cervix, see that you give her some tocolytics also till you call her up for follow-up. Because these patients need rest, tocolytics, if at all progesterone, and then you can slowly stop the progesterone and tocolytics depending on the need. So I think excellent talk, Archana.
Thank you, sir. Thank you so much.
I really enjoyed today because there is no one to talk to on either side. It's I'm at home. My wife is busy. My sons have not come.
Yeah, lucky. It was our good luck that
Yeah, I
you
enjoyed
know,
thoroughly. Thank you very
thank
much.
you so much.
Congratulations.
And it was really nice to have your inputs onto that. I think I'm onto it that we should have simpler things which can be used by every obstetrician. High technology is there, and we all have to use it. We have to learn it. Artificial intelligence is also there, but still we are practicing in India, where like if you say 70% of the population is not having access to the technology, which I think moves us to a basics. The basics has to be done very well. So thank you very much, sir, for being with us. Over to you, Dr. Sushmita and Dr. Aishwarya.
So, Aishwarya, over to you for the next program.
I would like to invite Dr. Sushmita Mukherjee, madam, as a panel moderator. Madam is a gold medalist and a university rank holder. She is also an FMAS faculty member of AMASI. She specializes in IVF, infertility, advanced laparoscopy, and high risk pregnancies. She is also skilled in advanced laparoscopy during pregnancy, including lap and cerclage. She is also known to have removed 6 kg fibroids and 12 kg para-ovarian cysts. She is a certified cosmetic gynecologist and is also a regular chairperson, speaker, and faculty at AICOG, Foxy, ISAR, and other platforms. Receiver of Dronacharya Award and MP Star Award and IFS Achiever Award 2025. Over to you, madam.
Thank you, Aishwarya, for the kind introduction. And I'm really blessed to be in this webinar, a very important webinar. To start with, we have this panel on preterm birth case scenarios. So I will be sharing my screen. Is it visible?
No, ma'am, not yet.
So you can introduce panelists meanwhile, Dr. Aishwarya,
Yes.
while Dr. Sushmita is fixing the.
Aishwarya, please introduce the panelist. Remember? Screen the share.
Is Dr. Sampa here?
Am I
Is she
audible?
talking?
Hello.
Yeah, Dr. Sampa Rai Chaudhary, is she here?
We have our panelists, Dr. Shampa Roy Chaudhary, Secretary, Malda Obsgynae Society, Dr. Manila Jain Kaushal, past President, IOXA, Indore, Dr. Shankar De, Secretary, Asansol Obsgynae Society, and Dr. Amit Datta, Secretary, Bardhaman Obsgynae Society, and Professor Dr. Ratan Chandra Mondol, Secretary, West Midnapur Obsgynae. Share later. Aishwarya, please go through their CV.
Yes, ma'am.
Is it visible now?
Screen sharing. Visible, ma'am.
Visible? Okay.
Am I audible, ma'am?
Yeah.
The following, Dr. Professor Ratan Chandra Mandal. He is professor and department.
Aishwarya, you are not audible.
Hello.
Aishwarya, yes.
Ma'am, there is some network issue. Hello.
Yeah, you are audible.
Hello.
Yes,
Am I
yes.
audible, ma'am?
Aishwarya, you are audible. Please go
Yes,
to
ma'am.
the CV. I think there is some network issue. Am I audible?
Hello.
Am I audible?
Yes, ma'am.
Okay. Now, medicine is a science of uncertainty and art of probability. Guidelines cannot override the healthcare professionals' clinical judgment in diagnosis and treatment of particular patient. So, preterm birth, the WHO theme on prematurity, a strong start for a hopeful future. It was launched in 2008 by European Foundation for Newborn Care. Now, it has become a worldwide event. French doctors first used fetus way back in 1880. Now, what is the definition? It is born before 37 weeks. If they are born before 28 weeks, then it is extremely preterm, very preterm 28 to 32 weeks, moderately preterm 32 to 34 weeks, late preterm 34 to 36 weeks. Every year worldwide, 15 million newborns are born preterm. So why a major cause of concern? Because of the short and long-term complications. The short-term complications can be respiratory distress, RDS, apnea, intraventricular hemorrhage, PDA, necrotizing enterocolitis, sepsis, and retinopathy. The concerns of prematurity, as we all know, the long-term complications can be asthma, lung infection, cerebral palsy, heart failure, feeding difficulty, poor immunity, and hearing loss and blindness even. So, who are the women who are at risk? Now, may I have somebody from the panel to answer to this question, that what are the risk factors for preterm birth? If we are taking a history from a lady when she is visiting our chamber, then there certain things we have to cover in history, we have to ask her, and they are very significant. So somebody from the panel, can you please take this question? What are the risk factors for preterm birth? Dr. Shampa, Dr. Shankar, Dr. Amit, Dr. Ratan, Dr. Aishwarya.
Yes, ma'am. Ma'am, previous history of preterm birth, like if there is any history of second trimester loss,
I think that is the most important history we should never miss.
Yes, ma'am.
Previous mid trimester loss. and if there is a history of short cervix in previous pregnancy. And if this pregnancy, there is multiple pregnancy, if the patient has some kind of uterine anomaly, say biconnuate uterus or septate uterus or uniconnuate uterus, then also we will have to be very careful. Or there is some history of PROM and some cervical surgery history in the form of, say, lead or conization or anything of that kind. So, prediction of preterm birth. How do you predict preterm birth? This is a very important slide because once the preterm birth is established, then we have very little to manage. The best effort should be to prevent it. So, whom will you prevent? Only when you can predict that this lady can develop preterm birth. So, how will you predict preterm birth?
Ma'am, we can measure cervical length during the NT scan 11 to 13 weeks.
Excellent.
And ma'am, recurrent if the patient has white discharge or any history of infections. So
It is very important because infection, inflammation, these are very important precursors for preterm birth. And so adequate cervical length is important. And if the cervical length is less than 2.5 centimeter, then it is a high risk mother. And if it is less than 1.5 centimeter, then it is a very high risk for preterm birth. Now, can you mention some biochemical markers through which we can predict preterm birth in the first trimester?
ma'am, PAP-A usually or CRP maybe.
Yes, PAP-A, low PLGF. These are related with fetal growth retardation, placental dysfunction, and some way they are also related with preterm birth. Apart from that, there are certain inflammatory markers also. They are also precursors for preterm birth like interleukin 6, TNF-alpha, and CRP. So now in this presentation, I have taken two cases which are very rare, and fortunately we could give a favorable outcome. And at the end of the discussion, I will take opinion and I will take from seniors who are here in this meeting, whether they have also come across such kind of situation. Now, a 24-year-old infertile lady who has undergone IVF, and she has a twin pregnancy from GV, which is also a very, very rare case. At 17 weeks, she develops fever, cough, cold, occasional headache, and she got admitted. Chest physician attended. There was not much relief. Patient getting treatment got admitted twice, but still she is unwell. Now, anomaly scan has been done. It is fine. The cervical length is fine. Routine investigations show features of mild leukocytosis, but we find that the CRP is persistently raised and the ESR is also raised. Now, 22 weeks, patient calls me that she has some weakness in the left side and she is unable to walk. She comes to my clinic limping. I get her admitted, and in the hospital, we find that she is bedridden. She is unable to sit, she is unable to walk, And next morning, there is retention of urine and she has been catheterized. So now we have no other choice but to go for MRI brain and with a shield chest X-ray. So I would like to ask you what may be the reason, what are the things going on in your mind when you have such a patient who has a history of cough cold for some time with fever, not resolving. She has been given all kinds of treatment, antibiotics, everything suddenly develops.
Hello, Dr. Sushmita. Yeah, I
Yes,
was not able to join. I was listening to your webinar throughout. So I just got the link to join. So I was listening
welcome,
to the
Anita.
case. Yeah,
Welcome.
yeah. Thank you so much. Thank you.
Thank you for joining.
This is an interesting case, I think. And as you mentioned, the patient had history of fever with cough. We think about tuberculosis, but it could be something else as well, like any lesion in the brain that could lead to this thing. The symptoms what with patient came with.
Excellent.
So
Excellent. So now we have a lady who has some kind of infection, inflammation going on, where even the brain has been involved. So now comes the MRI report, where we find that there are multiple lesions within the brain resembling tuberculosis. Now, in this case, initially when the chest physician was attending, I was insisting that I suspect maybe she has tuberculosis. Why isn't she responding to antibiotics and all the so much of treatment? But they were very reluctant because they told that no need to go for X-ray. Let us wait. She will improve. Now, what is the have anybody of you come across such kind of a patient, a pregnancy where a patient develops a brain tuberculosis and later on develops preterm labor also?
I haven't, ma'am, so far. That seems to be very interesting to me.
Yes. Now, the patient is IVF treated, conceived, twins. After a long time, she has conceived, and now this thing is going on. She is in the hospital. Now, generalized inflammation going on due to tuberculosis involving brain. This is our diagnosis for the time being. Now, what next? She gets pain and bleeding. So we start tocolysis. It is 24 weeks. We know we can't do anything except to prolong it. So I would like to ask you, what will be the choice of your tocolysis here in such a patient?
A little tricky here. I mean, I'm not sure about like tuberculosis. We can, not give progesterone or etoposide or nifedipine. But since she is just 24, is she started contracting?
Yes,
Yes.
she started contracting, she started having bleeding, and the pain would be excruciating. She would have severe pain. So we were at a loss. We were almost sure that she's going to deliver. The anti-cox treatment, meanwhile, has been started. Within few days, we could find that the patient has started recovering. She's able to sit, able to stand, and within a matter of 10-15 days, the catheter could be removed, the bladder control also. So we were happy that at least our diagnosis regarding tuberculosis is fine and the patient is improving. Meanwhile, she started having pain and bleeding. Now, here comes the role of tocolysis because we were desperate. This is a twin pregnancy, IVF treated. And since with anticox, she started improving. So we opted for atosiban because this is a drug which has minimum side effects, be it cardiovascular, be it whatever on the mother. So the message is a patient who is ill or who has some cardiovascular problem, in that case, we cannot give isoxsuprine, we cannot give nifedipine. Even here, atosiban is still better. And in this case, we gave her the entire dose of 48 hours. And apart from that, there was a supportive treatment with progesterone also. When she recovered, then we would add isoxsuprine intravenous drip also. So she was managed till 28 weeks.
Did you apply cerclage, ma'am, later?
Her cervical length was throughout normal.
Okay,
So
that's
here
good.
is, yes, we never applied cerclage. In spite of being a twin pregnancy, there was no need for cerclage. She didn't dilate. The main purpose of discussing this case is that inflammation and infection can lead to such event. So she undergoes cesarean, and a girl 980 gram and a boy 860 gram were delivered by cesarean, and they were shifted to NICU. Now, is inflammation a cause of preterm birth? Is
Yes, I think
infection,
so. Yes,
is
yes.
infection a cause of preterm birth?
So whenever there are
be, ma'am.
pro-inflammatory, yes, ma'am, could be.
So I would like to know the pathogenesis, what exactly happens in case of generalized infection or some kind of local infection, or do we need to take care of local infection very seriously in case we want to prevent preterm birth? And I would also request you to mention what may be the probable organisms which will lead to preterm labor and PROM. How will you prevent and treat? So, what is the pathogenesis basically? So, there can be ascending genital infection, there can be subclinical intrauterine infection, maternal systemic infection, and sometimes there is sterile inflammation without infection. Now, the common organisms which can be, Aishwarya?
E. coli.
Yes.
Mostly.
Bacterial vaginosis is
Gardnerella vagina. Gardnerella vagina.
yes. Mycoplasma.
Mycoplasma.
Yes. Ureaplasma. Group B is Streptococcus, and now from this case, even Mycobacterium tuberculosis. Now, what is the pathophysiology? They will release some inflammatory mediators. What are they commonly?
Interleukins.
Yes. Interleukins, TNF alpha, and they lead to production of prostaglandins, which lead to cervical ripening, membrane weakening, and uterine contraction. So the result is preterm labor with or without PROM.
From.
So this patient had a very the purpose of keeping this case was that in spite of being a very difficult and very every time there we will face some kind of surprise from this patient, and we will be in a position that we will be absolutely hopeless that how am I going to manage this case. And every time counseling such a patient, it would be extremely difficult convincing them that, okay, wait for some time, maybe there will be favorable outcome. the most favorable outcome which we got in this case was that both the babies recovered in the NICU and there are no long-term complications and they are almost 1.5 years old now and very healthy. And yes, apart from tocolysis, the neuroprotection part with Maxell was also taken care. Now, this is the second case where a 28-year-old lady comes with leaking at 22 weeks. Now, I would like to ask you, what will be your counseling part in such a patient?
So at 22 weeks, the prognosis is little, borderline because we don't consider this as a period of viability.
Absolutely.
So if she
Absolutely.
leak at this point, we have to first explain what she is suffering, the whole family, the entire family. And obviously, we are going to support this pregnancy further. We don't know how much she's going to take it further. But yes, we have to explain them all the realities, uh, along with, a pediatrician's opinion, because the patient doesn't want to lose pregnancy at all, and they're not ready to accept things at first go.
Yes, she has a similar history in last pregnancy with an abortion at 6 months. So from the very beginning, she is a very high risk case and she would have been treated in a different way with certain preventive medications which we should have started earlier. And somebody can tell about the preventive medications which we can start in this kind of a patient from the very beginning?
I think prophylaxis for bacterial vaginosis. I mean, first the detection, and we have to take care of the vaginal infection in this such cases, so that ascending infection could be prevented. Roll up pre-probiotics, then we
Very
can put her on progestogens as well.
yes.
Uh, Also, we have to look for the infection as what you were discussing in your last case. So any
Yes.
subclinical infection can also trigger, her preterm labor or leaking. So we have to be very careful. We have to find out the cause as well. That and the serial monitoring of transvaginal scans. It is also important. Looking into the uterine anomaly, I believe it must be checked in this case before.
So
So
will you admit this patient or she will
uh,
be managed in the OPD?
So with this leaking, first we like to admit to know the cause, what is actually happening. For a while, we will admit to investigate her, do all her blood test, sonography. You know, uh, we have to observe what was the cause and what we can treat. And once we are sure that everything is under control, and they also understand the prognosis and the follow-ups, we can send her home, and she can be managed at home as well. Uh, Before that, we have to be sure that both the mother and the fetus is not at risk.
Now, Manila, I would like to ask you, in such patients, do you find that they eventually have the leak heals up and she stops leaking and there is an intact membrane? Do you find it very frequently or it is almost impossible for a patient at such a gestational age to have a healing of the leakage?
So, ma'am, to be honest, uh, we don't see this stop of leaking at all because once the membrane has breached and there's a frank leaking, it will happen. There are many medicines available that they claim that bleeding, this leaking would stop, but I haven't came across, and we have to understand this fact. Although the patient and the attender will always ask you for any remedies for the same, but we have to be truthful about
To
our
be,
own experience. Maybe you would have seen, but
to
I
be
have never.
very honest, about 8 out of 10 patients will have a persistent leak and eventually at such a gestational age, most probably she will deliver. Now, Basit ma'am is there. Ma'am is there. Shah sir is there? PK Shah sir is there? Okay, mostly in this kind of patients, the leak will not heal up and the leak will continue, and eventually the patient might deliver. But in this case, we were fortunate enough that after a while, the leak stops and we continued with our treatment of tocolysis, steroids, Maxalt, and antibiotics. And the patient got delivered at the gestational age of 37 weeks. It was a very rare case. The attendants were very keen to have the baby and they were ready for everything. Now,
The
tocolysis,
mother was very fortunate. I mean, very lucky, and it's
yes,
very rare to see that. And even at 22 weeks, there is a high risk of pulmonary hypoplasia in the fetus as well. So
yes.
you're really lucky. The patient was so
I
lucky.
was lucky, the patient was lucky. Now, if
Yeah.
it's a question of tocolysis in such a patient, when will you tocolyze? What will you do? How and what not you will be doing? Will you be using Maxalt, nifedipine, isoxsuprine, indomethacin, or atosiben?
So my choice would be atosiben, but ma'am, I wouldn't be giving it for a case of prom.
Yes. The problem is if 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 it is a prom, then the primary thing is you will have to start with some antibiotic. Now, meanwhile, if she develops pain and you intend to prolong the pregnancy, then definitely you will require some kind of tocolysis. So, would you consider Maxalt as a good tocolytic agent? Maxalt is supposed to be a very good agent for neuroprotection, but it is not considered a very good agent for prevention of preterm birth or for tocolysis. And it reduces cerebral palsy, severe motor dysfunction, neurological injury to the fetus, stabilizes fetal neuronal cells, and prevents ischemic injury. So, would you choose nifedipine?
Yes, ma'am, nifedipine can be given, especially when there is a cost constraint. So obviously, everybody can't afford atosiben, although atosiben would be always my first choice. But in all cases of leaking, we have to give tocolysis only to cover the action of the steroids. We don't need not to give it for long term.
Yes.
So yeah, so that is my stake.
It was a desperate attempt, you know. Sometimes, you know, we have patients where they leak, we still keep the patient for some time, hoping that the leak seals and the patient pregnancy continues.
True,
So,
ma'am. True, ma'am.
yes, to be very, very honest,
Yeah.
you know.
Yeah,
And
yeah, ma'am.
it
You know,
may so
situation, there are
happen.
always exceptions. We have to do it in the best of the patient, in the best good of the patient. So,
Yes, yes, for the benefit of the patient. So now, what is the contraindication of tocolysis in such a case? If there are features of chorioamnionitis or if there is fetal distress, IUD,
under Lilo. Under.
है ना? Now, isoxsuprine is old beta-2 agonist being used for ages, but in a smaller setup, it is very useful, isn't it? And till date, sometimes we are using it. But it has its cardiovascular risks. Atosiben, as we know, it is the oxytocin receptor antagonist. It blocks prostaglandin release And the dosage is for 48 hours, ideally in case of preterm birth, where we give a bolus 6.75 milligram over 1 minute, then a high dose infusion of 18 milligram per hour for 3 hours and 6 milligram per hour for 45 hours. It has less tachycardia, less hypotension, less pulmonary edema risk, safe in patients where we don't want to any cardiovascular risk. Only problem is it is very expensive and it has to be given in a hospital setup, intravenous, unlike nifedipine. It may cause nausea, headache, injection site reaction, dizziness. Now, would you give, this is a general take-home question, that after 34 weeks, if there is a preterm labor or a PROM, would you give steroids or not? So it is the, yes, yes.
Yes. I will not give steroids because let the nature works for it, right?
Yeah, it is being told that steroids beyond 34 weeks will lead to neonatal hypoglycemia and prolonged NICU management. Like we are doing more harm by giving steroids beyond 34 weeks. Also, neurodevelopment, yes, neurodevelopmental problems and mental and behavioral issues in such babies as long-term complications. So after 34 weeks, there is no role of steroids. So probably it is better to deliver the baby. Even the role of tocolysis is also not very much after 34 weeks. However, ACOG recommends a single dose for selected cases where delivery is going to happen within 7 days between 34 to 36 weeks. This is something exceptional. And it's beneficial to deliver such a baby rather than dealing with steroids. Antibiotics, if there is a preterm labor and the membranes are intact, would you give antibiotics? Is there any need? Mostly there is no need because it will cause more harm to the mother and baby. When will you give? You will give when you suspect chorioamnionitis, also if there is a GBS prophylaxis need or the culture is positive. What are the benefits? It helps in prolongation, reduce maternal sepsis, chorioamnionitis, reduce neonatal sepsis, need for respiratory support, surfactant need, everything will be reduced. So mandatory in every case of PROM. Also, it reduces inflammatory response in the amniotic fluid. So what are the antibiotics used? Ampicillin, erythromycin, amoxicillin. And sometimes in case of chorioamnionitis, you have to give a broad spectrum coverage, including gram-positive, gram-negative, and anaerobic. Amoxiclavulinic acid, should we give it in PROM? It should always be avoided. It is contraindicated because of the risk of necrotizing enterocolitis. Cerclage, we have a detailed discussion on cerclage. It can be vaginal, laparoscopic. Role of MGSO4, I think Pikesha sir has given a detailed discussion we had today on MGSO4. But the main role of MGSO4 is for neuroprotection rather than prevention of preterm labor. That is, it is not a very good drug for tocolysis. Rather, it is a very good drug for neuroprotection of the fetus. What was the outcome of this patient? We were fortunate enough to have a very favorable outcome. Usually the outcome is bad. This case, patient had a favorable outcome. The leaking stopped. She had prolonged hospitalization, antibiotics, tocolysis, Maxalt, steroids were given. At 37 weeks, cesarean birth, 2.7 kg male baby, and he was named Kanha. Not everyone is so lucky. We obstetricians face day-to-day challenges with mothers and try our best to give a favorable outcome where every mother waits for us to get a live baby breathing, crying, moving hands and legs. Sometimes science fails and there is no other way but to pray to the Almighty for a favorable outcome. Prayers, patience, and science do work, as you can see in these two cases. May we achieve more in saving more lives. So the efforts continue, results awaited, more addition to our knowledge and expertise. I would like to thank our esteemed faculty for your valuable insights. We are grateful, and sincere thanks to Farmate who has given us this platform to have this webinar on a very special and very important topic. And Sudeep ji, I would like to personally thank you for all the help you always provide us and always bear with us. Thank you, Basil ma'am, for giving me this opportunity. With this, I conclude and I hand over to Dr. Aishwarya Verma. Dr. Aishwarya.
Thank you, ma'am. I would like to thank all the speakers for their valuable time and
A special thanks to Dr. Manila Jain Kaushal, who joined us for the panel. And I could inform her yesterday only, and she consented to it. I'm really grateful. And thank you, Aishwarya, for participating in the panel. So
Thank you, ma'am. It was very interesting. I was not able to join on time, and in between, I was not there, but it was very interesting panel.
You were
Very well
quite
built.
busy today, you told me, but in spite of that, you are so sincere. You joined. So we are very thankful.
Thank you, ma'am. Thank you.
So before I conclude, I would like to ask Basir ma'am if she wants to say some concluding words. Above all, we require support from मैडम हो गया आप कुछ बोलेंगे yes please so madam we have learned a lot from Basit ma'am. Today we had Dr. P.K. Shah with us, Dr. Naren Malhotra, Dr. Shamal Seth, all renowned speakers, faculty, and we have learned a lot that our main aim should be to prevent preterm birth rather than treating preterm birth. And over to Basit ma'am for your concluding remarks.
At the outset, let me thank convener for this webinar, Dr. Sushmita Mukherjee, for really taking efforts to bring us all together on this platform. Dr. Aishwarya Verma for being a very perfect master of ceremony with collecting everybody's, it's a great job. And I'm sure um, Aishwarya must have also learned from this experience. And thankful to our guest of honor, Dr. Shamal Seth, chief guest, Dr. Narendra Malhotra, speaker, Dr. P.K. Shah, and all our panelists, Dr. Manila Jain Koshal, Dr. Day, Dr. Roy, all those who have joined, I'm really, really thankful. And my special thanks to Sudeep ji at Format for ever ready and always giving us a seamless platform. Thank you very much and enjoy the rest of your evening.
And always bearing with us with
Yes. Yeah.
getting the CVs late and all these things, but he will never complain. So that
And
is
we would
important. Yes.
and we would request all those who are with us now to vote and support Dr. Archana Base for her
Thank
upcoming
you.
proxy presidential election.
Thank you, Dr. Manila. Thank you for your kind words. And always you people are with me and standing by my side and, always all around. So thank you so much. And
Thank
enjoy
you.
your
Have a
evening,
great evening.
Dr. Enjoy Dr. Sushmita, Aishwarya, and all of you.